Thank you for the opportunity to be here and present on shockwave therapy. A special thank you to Jason Powell. So going over today's objectives, we're going to talk about cellular healing and why shockwave therapy. We'll review some of the relevant literature on shockwave. We understand that there are various phases of healing that the body goes through with inflammation, proliferation, and remodeling. And so we're trying to guide the body through this. We're going to go over some machine-based energy with shockwave, or ESWT, that stands for extracorporeal shockwave therapy. And we'll talk, there's different types of shockwave. There's a radial, which is really a pressure wave, and there's a true shockwave, which has a much more potency and greater depth and penetration. So shockwave began in Germany in the 1970s when doctors discovered that machine-based energy, when applied directly over the kidney area, breaks up stones or ureter stones. And accidentally, they found that pelvic bone was regenerating and soft tissues were healing. But it's key to understand these are the two main types of shockwave. There's radial, which is not a true shockwave, it's a pressure wave. And then there's true shockwave, which is either focused or broad focused. And we'll explain that a little bit. And so over here, you see this is a radial pressure wave device, which is really more of a piston. And it's nice for soft tissue superficial injuries, like maybe lateral epicondylitis, plantar fasciitis, or trigger points, but it lacks depth and penetration, and it also lacks as much randomized controlled trials as a focused shockwave. Then there's true shockwave, which is either focused or broad focused, and this is a real workhorse where it penetrates much deeper, up to 12 centimeters, and depending on the device, it may go for a 1 centimeter width versus a 6 to 7 centimeter width. And this is ideal for bone, breaking up calcifications, bone edema lesions, and chronic tendinopathy, and has many randomized controlled trials showing its efficacy. This is an example of a radial pressure wave over here on the left. And you can see this piston device, and we'll typically use this for surrounding soft tissues. It can be unpleasant or uncomfortable over a bony prominence and more sensitivity. Next, you can see a focus device, and this is more pinpoint. What's really unique about this is patients will report their symptoms are being reproduced, where the technology actually seeks out inflammation and will reproduce it. And then lastly, this is a broad focus device, which is going to cover a wider area, but is still more of a true shockwave, penetrating 12 centimeters in depth and 7 centimeters in width. This is just a diagram of what I was discussing. And so this is a broad focus, almost like a flashlight or a light bulb. You can see this wide area, which covers 12 centimeters of depth and 7 centimeters of width. So it's not as user technician dependent. You're going to be sure you're hitting the direct area of need. This is the radial pressure wave in the middle. That's only going to go about 2 centimeters by 2 centimeters, about the size of a quarter. And then this is a focus shock wave that's going to have 12 centimeters of depth and 1 centimeter of width. And when deciding what to use, I'm always asked this, and I know many have heard, we'll start with a radial pressure wave and get comfortable. I actually recommend the opposite. I feel like if you're going to have one tool, you should have one that works the best and gets the best results, which is a true shock wave. And the nice thing with the broad focus shock wave is that it's less painful, especially over bony prominences. And athletes I found can be sensitive or turned off if something's too painful. So I tend to prefer to use this soft wave device, which is broad focus. Shockwave can be useful for myofascial pain syndrome. This is a cool video just looking deep inside of the fascia. And I know there are many fascia enthusiasts in this room. But what happens, the theory from overtraining and lack of recovery, is you get this buildup of acetylcholine, which leads to calcium release, tissue ischemia or lack of blood flow, hypoxia, reduced oxygen, poor energy, increased inflammation, proteins or cytokines, which leads to injury. So this is an interesting study looking at shockwave on the fascia. And we know that sensory innervation and nociceptors, or pain sensors in fascia, play a key role in pain generation with myofascial pain. Shockwave results in selective loss of unmyelinated nerve fibers, inducing long-lasting pain relief or analgesia. How does shockwave work? Well, broadly, we term what's called mechanotransduction, which is these vacillating energies that are going into the tissue that are quite powerful. This mechanical energy, it mimics loading in exercise without having to do the loading. And it's been shown to help promote cell migration, proliferation, and differentiation, all good things we want to promote a healing environment. Some of the short-term effects as far as the mechanism of action, there's a washout effect, which kind of stuns the nerves and affects substance P that affects our pain and floods the nervous system. So it's not uncommon for athletes or patients to describe immediate pain relief within 2 to 5 minutes, which sounds unreasonable or unrealistic, but it can happen from this effect. This can last for 2 to 4 weeks, while the true phase of healing and tissue repair can be up to 12 weeks. There's studies showing local anesthetic, if it was injected, for example, into a plantar fascia so you could jack up the energy, actually had a paradoxical negative effect. And so there's something about the human body actually feeling the shockwave is important for biofeedback for outcomes. This pain analgesic effect is so powerful, it's actually banned in racehorses 48 hours before a race. When we look at some of the long-term mechanisms of action, it alters substance P and CGRP, which helps provide pain relief, increases cell permeability and crosstalk between cells and membranes, releases nitric oxide, increases bone metabolism, promotes angiogenesis, which is new vessels, and osteogenesis, which is new bone formation, releases growth factors, and stimulates mesenchymal stem cells and bone morphogenic protein, all very important proteins and cells for repair and regeneration. For this talk, we don't have time to go extensively through all the literature of shockwave, but this is a comprehensive review that we published last year that I encourage everyone to reference for looking at how shockwave is a orthobiologic tool, almost like a non-injectable biologic that we can use to try to similarly stimulate the human body's inherent ability to self-heal or our endogenous capacity to repair. And this is a non-invasive way to try to promote healing. This is a unique study at cardiovascular cells showing that shockwave actually boosts stem cells or mesenchymal stem cells, or also called medicinal signaling cells. It induces angiogenesis, which is new vessel growth, and improves blood perfusion or blood flow via this process of mechanical transduction. So we followed up this paper with a large review that was just published this year in the British Journal of Sports Medicine, which is the first study of its kind, really looking at shockwave therapy in the athletic population. So we found 56 peer-reviewed publications that met our criteria, almost 2,000 athletes or active individuals, which included military cadets. And what we found was shockwave therapy is effective alone for certain conditions and soft tissue issues, including plantar fasciitis, lateral epicondylosis or epicondylitis, also known as tennis elbow, and proximal hamstring tendinopathy. It was also a helpful adjunct when used with exercise treatment for medial tibial stress syndrome, which is shin splints, as well as osteotitis pubis or athletic pubalgia, which was really impressive. And then in most studies, it's important to note that athletes were allowed to continue training and tolerated shockwave therapy with minimal side effects. So this is a very safe option for your athletes with minimal to no downtime. Studies have consistently shown that the shockwave energy can stimulate bone healing, penetrate the bone, and improve bone edema. This was focused high energy. All of these studies use high energy shockwave, comparing 2 sessions of focused shockwave to IV bisphosphonate. And so many of you may well be aware, many athletes get these bisphosphonate osteoporosis medications like Forteo. So a similar bisphosphonate was compared to shockwave, only 2 sessions and 40 patients. And the shockwave group had greater improvements in their pain scores, their function scores, and greater reduction in their bone marrow lesions at 6 and 12 months compared to IV therapy. This is another study looking at bone edema of the medial compartment of the knee. And you can see the medial compartment on these T2 fat suppressed MRIs showing this hyperlucent bright area of bone versus the femur is healthy bone here. You can see the tibia with bone edema and the femur is relatively unaffected. And so they found, again, high energy reduced 86% of bone edema lesions versus 41% of the control. Importantly, VAS, which is your visual analog pain scale, improved by 88% versus 42% control at 3 and 6 months. And then WOMAC scores improved as well compared to control. This is just a study looking at almost 5,000 patients and 50 trials, showing that shockwave therapy is beneficial for knee osteoarthritis, but it does vary in terms of the dosage, the energy level, and the duration, and the different machines and technologies. This is another study showing that shockwave enhanced ACL-specific remnant cell viability, proliferation, migration, and expression of collagen, TGF-beta, and VEGF, which are all very important regenerative cytokines and proteins in the body for cellular repair. Shockwave stimulates a paracrine regulation of surrounding cells. And I'm not sure if you're familiar with the term paracrine effect, but that's really key to healing and how a lot of shockwave works, as well as PRP and biologics. So the paracrine effect is basically stimulating the cells to then communicate and create change throughout the body. And so shockwave, as well as injections like taking a needle and injecting PRP, can induce, as we talked about, those existing MSC or stem cell environment to get back to work. So some shockwave talking points. Typically, patients will get one shockwave session a week for 3 to 5 weeks. When you're treating a pro high-level athlete, they tend to want more treatment, or bone edema will do more frequent. It's unknown in the literature. There's nothing published if doing more treatments per week equals better results. In terms of activity recommendations following shockwave, to be conservative, at least for your first session, and start with low energy. And then also they should avoid strenuous activity immediately following the treatment for that day. And the next day we recommend about 50% loading. And that's typically what I recommend for my everyday patients and weekend warriors. But some of my pro athletes, once we've gotten through that first treatment, we then begin to progress activity quicker following treatment. You'll find medicine is an art and a science, and you get these tools in your hand and you may incorporate them in your typical routines and find other uses. It can also be used on acute injuries for positive and faster return to play. And it has the potential to improve strength through enhanced mechanotransduction. I feel like the sky's the limit with shockwave. Once more athletic trainers and teams get their hands on these devices. Overall, shockwave is a very, very safe tool, but like any intervention, needs to be used responsibly. So there are potential complications that include temporary pain at the site. It could be sore that day or the day after. So you wouldn't want to try this out on a major athlete, if they were expected to play at a high level the next day and they've never had shockwave. Side effects may include headaches or migraines, which I've never seen in thousands of patients we've shockwave, reddening of the skin site, or blistering, or hematomas or bruising, which I have not seen in my practice, but theoretically has been reported and is possible, and something to be aware of, or tell your patients. If it happens, don't panic, but it's always possible. Tinnitus or ringing of the ears in sensitive patients, also haven't seen it, but reported in the literature. And lastly, there's debate about shockwave after corticosteroid injection. There have been cases of patients in the Achilles, for example, that had steroid injection and then shockwave and had rupture of tendon. And it's unknown if the shockwave precipitated, vulnerability in the tendon causing rupture, or did the shockwave just not protect the cortisone that was given in the tendon. But either way, in your athletic population, hopefully none of your high-level clients and athletes are getting cortisone to an Achilles tendon, which can definitely cause tendon weakening and tearing in and by itself. What I want to highlight here is, although it's early and trending and we need a greater N in terms of a sample size, but when you look at the energy or shockwave device only, it's outperforming the biologic injection only. And so granted, that this is the KOOS score, and so you want to have a higher score, a higher function as your outcome. You can see the biologic patients started with greater pain and limited function, and maybe that's why they were selected for biologic injections versus those that had machine energy or shockwave. But it was a dramatic, profound improvement that we found from shockwaving patients compared to biologics. We also looked at the data across our registry of 251 cases to answer the question, well, how many shockwave sessions do you need? Can you just get away with one like they did in the rat study for meniscus injuries in the avascular zone? And what we found was one session, which is going to be this brownish tan line, really doesn't move the needle, which is what we expect in the office. So you really have to tell your athletes you need between 2 to 5 sessions. We really recommend 3 to 5 at a minimum for results. And then what we also looked at, which is going to be in the blue section here, is, well, what happens if you shockwave 6 to 10 versus 2 to 5? And we found better and greater improvements. So if you have access to the machine and your athletes are positively responding to shockwave, you may want to consider, based on our internal data, shockwaving more versus the literature suggests 3 to 5 once a week. We find greater improvement with more shockwave if needed. Many of our patients, once they're healed, we recommend maintenance therapy. So let's say someone had plantar fasciitis, which is probably the #1 indication for shockwave therapy. And they've had 5 to 10 sessions and they're healed, but now they're in season. You may want to think every 3 to 4 weeks of just hitting that with shockwave at the plantar fascia calcaneus to keep the pain, keep the problem away and that vulnerability. Lastly, we looked at different devices. And so this is objective measurements and data looking at 251 patients that had shockwave therapy. And so we compared those 3 devices you saw before, which are the broad focused or soft wave, to the focused true shockwave of Stores, which is more like that pinpoint energy delivery, as well as to the radial device, which is this orthopulse. And we find is all the different shockwave devices help and reduce pain in patients, but the radial had the least impressive effect. And then what was interesting here, according to the data, was the soft wave or the broad focus, the flashlight bulb type shockwave. Those patients started with higher pain scores, yet had the same degree of VAS or pain score in the end. So they had a greater improvement than the Stores focal, but both were very effective in reducing pain. I want to thank everyone for allowing me this opportunity to share our experience with shockwave. And I hope at least I'm opening some eyes and ears to the potential benefit of shockwave as it kind of tilts more towards mainstream.